while the patient is legally or competent enough to make their own decisions. And so that's a problem. Sometimes that becomes ethical as well, because they think they're supposed to make all the decisions, but it's only for patients who are no longer competent. That's what it is, okay? Remember the living will. It describes the patient's preferences and gives instructions to us as healthcare providers. If sometime in the future the patient is not able to make their own decisions or to communicate and has no appointed proxy, so if they don't have power of attorney for someone, then that's what the living will would be as well. So these are the two types of advanced directives, is the durable power of attorney and the living will. Two types of advanced directives. All right, so just quick terms there. Okay, just some more terms here. I'm just going to put them all up here for you. Some basic terms here about what injury means, malpractice, negligence. There's private and there's public laws, of course, and then there's standards of care. That standard of care can be professional or could be standard of care from just being a person on the street. The standard of care is different. But for nurses, we're familiar with those standards of care, how we take care of patients and what we need to do in events of emergencies. So just some terms there your textbook brings out. So remember that nurses, because we are nurses, there are legal risks and they intensify as we stay in the profession. And there can be lots of legal questions that will come up if you're working particularly in geriatric care settings. We definitely see a lot more legal risk. The geriatric nurse functions independently for the most part, and they make decisions without a lot of resources and a lot of professional contacts around. They may have professional contacts, such as doctors or nurse practitioners, but the nurses who are geriatric nurses really have a lot of autonomy in what they do. A lot of times they supervise, of course. You know, we always are supervising both licensed and unlicensed people, staff. And we as nurses are going to be responsible for the unlicensed person and the licensed person that's working under us for their actions. We're going to be held accountable, all right? Or responsible, I should say, responsible for their actions. There are lots of problems that older people may have that can lead to legal issues. Stakeholders, family members, such as family members and friends who are involved in the patient's care, we have to actually help answer some very, very difficult questions or get these people into the right resources to be able to answer those questions. And we know that our older population is extremely vulnerable, and they're scammed a lot and they're vulnerable, but they are protected under multiple different types of laws out there. So some of the laws that we do have, the laws will vary for our gerontological nursing practice among the states. They are lots of them. They can be complicated. They cause a lot of exhaustion, lots of learning, got to do a lot of teaching, and we have to make sure that we are adhering to each of those laws. So if you are going to be a gerontological nurse, practice nurse, you have to really understand the different laws, and it can come from the federal government, the public, it can come from the Board of Nursing, and all of those things, private as well, right? And of course, we are, as nurses, are governed by our standards of conduct. So, by the way, this is a link to the Board of Nursing, and we will visit that most likely in senior seminar, but I have the link here for you, and that we'll be talking about uh, licensure and all of that stuff in senior seminar, because we're going to help you get all that taken care of. The school will do that and help you with that. Okay. So if you wanted to go and explore the Board of Nursing for that, there is the link for that for you. Most of the time, I will say that nurses don't commit wrongful acts deliberately or intentionally, but sometimes certain situations are going to increase that liability. For instance, if you don't have enough staff to work on your unit, in other words, you don't have sufficient resources, or perhaps you don't have enough IV pumps, and you know most IVs now must be on an IV pump. You don't have it, something happens to the patient, you could be held liable for that. There's lots of agency policies and procedures. We must follow those. All right. Again, on the NCLEX, though, remember it's kind of like the perfect world. It's kind of generic for the policies and procedures, and standards of care is what they test you. But when you're working for someone, and those of you who are working or have had an opportunity to work in healthcare, you know there's all kinds of policies and procedures that you have to follow. So be sure that you are following those. Even a one-time deviation of bending the rules can result in serious legal problems. It doesn't take but one time of bending rules and something happens. Taking shortcuts is not a good thing to do. Another thing that we see a lot of these days is because nurses are working those long 12-hour shifts. Usually they wind up to be 13 hours, 12 and a half, 13 hours, maybe even longer, 3 days in a row. That can actually cause physical and emotional exhaustion. So be very, very careful, class, wherever you work, regardless of whether it's a gerontological nursing or whether it's just a nurse in an ICU or wherever it might be. Watch that physical and emotional exhaustion, because mistakes are made. And they've done research, and what it amazes me, and of course this is a Professor Stevenson opinion, okay, this one is my opinion, is that they have done research studies on 12-and-a-half-hour shifts on nurses. And they realize that by the 8 hours or so, nurses are exhausted. They can't think straight. They don't think as straight as they should. And that's where a lot of times the errors are being made. So think about that. And the hospitals do have these long shifts because it's cost effective. You know the reasons for that. But consider that when you are working. Make sure you get lots of sleep and take care of yourself. Okay. All right. Here's some things that can increase your liability. All right. What is assault? Who wants to tell me what assault is? Tell the class. What does assault mean?
Threatening.
Yeah.
Threatening to do something.
Threatening to do something. So I'm going to lock you up in a room without food if you don't stop being quiet, if you don't stop yelling. You know, that's assault. If that occurred in a long-term care facility, they call that abuse. Verbal threats, absolutely. What is battery? Oh, it says you, I'm sorry, it tells you. Okay. Touching that causes another pain. However, battery can also be if we do a procedure on a patient without their permission or consent, that is considered battery. That's why we have taught you all this time the first steps of when you're assessing your patient and or having to start a procedure. We generally say, I'm going to put an IV in your arm now. The doctor wants to give you some medication. Is that fine? You know, is that okay? Or something to that effect, because we need their consent. When patients come into the hospital or into the nursing facilities, there's certain things that we do that what we have implied consent. But anytime, whenever you are going to put a catheter in, start an IV, even change your dressing, be sure you let the patient know what you're doing and make sure that they're not unhappy with that, because that could be considered battery. All right, just something to think about. All right. Defamation can be slander or libel, of course. Slander being what? What is this? Give me an example of slander.
Slander's when it's written, right?
Slander was when it's spoken.
Talked, spoken.
Yeah, absolutely.
Behind someone's, like spoken behind someone's back.
Yes, speaking poorly about someone.
Yeah,
You can remember slander by thinking of S, meaning speech. That might be a way to remember. Libel is written. If we write something negative about someone, like if you're sitting in a meeting and you write something nasty about one of the patients and you pass it to your friend, well, that's going to be considered character defamation, which would be liable. So y'all, be careful what we say and do, of course. False imprisonment. What is that? Can you give an example of false imprisonment?
Having all four of the rails up.
Yeah, we could actually consider all four rails up could be false imprisonment. Absolutely. Locking someone in their room, like in a nursing facility. There have been cases where patients have been locked in their rooms, right? Because they wander around. So that's definitely going to be that's a lawyer waiting to happen for sure. So that would be something like false imprisonment. The other thing that's increasing our liability as nurses, there's a potential for fraud. Now, excuse me, fraud is intentional, it's willful, and it's a misrepresentation that could cause harm or loss to a person or property. So you've heard of a lot of cases of fraud, all right? Stealing money, those types of things. So, and it's willful, it's intentional. Okay, we have to be careful when we're taking care of our patients. There have been times when like a certified nursing assistant or nurse that's been taking care of someone at home, they're stealing their credit cards. That's definitely some fraud going on there, and using the older person's credit cards, all right, or taking money from them. That's definitely fraud. Okay. All right, and then of course you're probably remember negligence. Negligence can be either omission or commission of an act that departs from the normal, acceptable, reasonable standards. It could be not doing it or doing it. All right. So either one could be considered negligence. For malfeasance, for a nurse to perform, listen, if a nurse who is not a surgeon or not a nurse practitioner and has learned how to do some type of surgery, if you decide you're going to do some kind of surgery, right, no matter how tiny it is on a patient, that's going to be considered malfeasance. Malpractice and malfeasance, actually. Okay. Malpractice can also be like, for instance, when you put an NG tube in, you have to check the placement before you ever give meds, fluids, or foods. Always remember, if we fail to do that, not checking, we are not following the standards that we have learned for our profession, and that will be considered malpractice. Okay. So just some terms to remember there. So someone who is not going by the reasonable standards, of course, is negligence. And we did talk a lot about that. I don't know if y'all remember fundies. We talked a lot of that stuff in fundies. But just to bring it back to your memory, to put it on the front page of your head here, some situations that could result in negligence for nurses, failing to take action. In other words, if we see that a patient is having some difficulty breathing and we decide not to do anything about it, well, that's going to be negligence. There's lots and lots of examples that you can think of for negligence. Not monitoring a patient appropriately, not contacting the healthcare provider when there's a problem with the patient. All of those types of things can be considered negligent. Contributing to a patient injury can be considered negligence. and could lead to malpractice if the patient gets injured. For instance, if we know that we're supposed to keep the top 2 side rails up or all 4 side rails up when a patient is under the influence of some kind of narcotic, and it's a policy in your facility, and we fail to do that, the patient falls out of bed, then it can obviously falling out of the bed because of the rails weren't up could contribute to the patient's injury, so that could definitely result in negligence, and eventually to malpractice particularly. Okay. If you fail to report a hazardous situation, for instance, if you're walking down the hallway and there's a whole puddle of water on the floor and you just walk right past it and don't even tell nobody, oh, that's bad, because somebody could fall, and if they do fall, you're going to be held negligent for that, especially if you knew about it. So we have to do something. We don't just leave it up to our environmental services, the housekeepers, things of that nature. We have to do something. If there's a IV cord that's frayed or bed that's broken, the light doesn't work on the call light, when they press it, oh, definitely you need to report those immediately. Okay. All right. Patients can be damaged and hurt by that. Be careful with handling possessions of a patient. If we lose somebody's dentures, that's going to be negligent. And of course, the hospital wind up having to pay for those dentures. So handling patients' things inappropriately is definitely something that we need to be watching for. And be sure that you follow policies. Following the policy is the best policy. All right. So one of the first things that we talk about when we talk about legal issues is what was the policy and was it followed? That's the first thing that's going to come up in most cases. So we know that even in gerontological nursing, all of these can cause negligence. Well, what about malpractice? Well, it depends. Some of the injuries can be deemed as, say, accidents. Others can be deemed as unavoidable. So there are policies. So whenever something does happen, be sure that you document as quickly as possible, make sure it's factual, and that you have everything specifically laid out if something has happened to a patient. Notice that negligence acts do not always warrant damages, and that damages meaning money. Usually it's money. However, malpractice tends to have money associated with it. Okay. Remember that it is our duty to take care of our patient. If we are negligent, it can warrant a malpractice lawsuit eventually. If one of our patients is injured, whether it was our fault or not, it probably will still become a malpractice. Whether the nurse is charged with that depends on the situation. For instance, nurses who have accidentally given the wrong medication to a patient and caused some serious injury to that patient, not only were they negligent, but because of the injury, they're probably going to get some money compensated back. So that would be probably a malpractice lawsuit. Just a review there for you. So, actually, I gave you the answer already. Incorrect dosage of a medication is an example. Not using the proper lifting techniques. That's why we really stress that we know how to properly position and reach and transfer our patients, to use those mechanical lifts whenever we can, when they're available. Because if we don't and a patient falls because of our negligence, it's going to become a malpractice lawsuit. But the other thing too, if we delegate to the wrong person some type of task, say for instance, if we delegate, let's say if we delegate to an LPN to go push some medication for you because this patient needed some furosemide and you're really busy, so you hand the syringe over to an LPN and tell them to go push that furosemide, that's definitely a malpractice lawsuit. okay, because it was improper delegation. Because remember, the LPN cannot push medications, right? Particularly based on the NCLEX, and pretty much in every state, they can't push medications, okay? And I already mentioned, I have another note here. I want to make sure if we notice a change in a patient's condition, but we fail to notify the physician, that's a potential malpractice waiting to happen. If we leave something at the bedside and a patient drinks it and they're confused and they have an adverse reaction, definitely a malpractice. So think about it. If you're, say you have a patient who's confused and you have wound care for that patient and you leave the bottles of, let's say, normal saline or sterile water, whatever you have, and that patient gets a hold of that and something happens to them because of that, it will be a malpractice. So know your patients. Keep those things away from the bedside table. Don't leave stuff at the bedside table or where they can reach it. Okay, that's important to remember. If you forget to turn or reposition an immobile patient for an entire shift, that's not good. All right, that's going to be a malpractice as well, because you know what could happen in mobility and the effects of that. And if you don't have enough help, I mentioned already, for a patient, when you transfer them, of course, falling is a major issue. And we still have a lot of issues with falls in our profession. So when can damages be recovered? We sort of talked a little bit about this some time ago, but basically remember that for malpractice to exist, duty, negligence, and injury must be present. Was it my duty to take care of this patient? Did I not follow the standards of care? Was I negligent? Did my fact that I did not follow the care or the standards or policies of my facility, did that contribute to the fact that my patient got injured? So all of those have to exist and be present, and before damages can be recovered, all right? So, or proven that it was malpractice. So one of the questions that is asked a lot of times is it reasonable to conclude that the nurse should have known the proper practice and action? Always a question that the lawyers like to ask. Is it reasonable that we believe that this nurse should have known about how to transfer that patient correctly? Were they educated on that mechanical lift? Were they aware of the policies of the facility? Did they know the condition of the patient? That is so crucial, because legal is going to ask those questions if you ever get a lawsuit against, if the nurse gets a lawsuit and something has happened to a patient. That's one reason, class, I tell you as a student, and even as a nurse, really, if you're taking care of, like you're on the unit, whether you're a registered nurse or not, and you're on a unit and somebody calls for the call light and you answer that call light and they want to go to the bathroom, right? But you don't know the patient. You don't know all those things about the patient. If we help that patient to the bathroom and they fall or something else happens to them, we can be held definitely in a malpractice lawsuit, and damages are going to be recovered for that most likely. And so again, just think about it. Should I have known this, or should somebody else have known what they should have done? So be careful when you are helping patients from another room before you get them up, or so ask, find out. And there's many other questions that we could to talk about. So how can you prevent malpractice? There's a box here I want you to take a look at. Be sure you know your Nurse Practice Act. That's number one. Make sure you know and follow it. Understand HIPAA. If you're not sure about our order, if you see an order and it doesn't make sense, or if they've handwritten it and it's unreadable, you have got to contact the healthcare provider. Don't just assume what you see is what the doctor wanted, okay? Be sure you know your patient's baseline normal status, whether it's vital signs or overall health status, because if you know that, you will be able to identify changes that are occurring in your patient. So be sure you know your baselines at all times. Assess, reassess as much as you have to, all the time, basically. Every time you walk in a patient's room, you're assessing that patient. You may not say all the words and the fanciness about assessment, but you are assessing the patient. Be sure you're following the plan of care. When you're giving medications, make sure you do your 6 rights, the 3 checks, all of those things, okay? Follow the policies and procedures. If you don't understand something, please ask, find it in their policies, whatever you need to do. If you're not sure, if you've never done a particular procedure at a hospital or that facility, be sure you find out before you do anything. And if you're not sure what you've been asked to do, or that you're asked to delegate, if it's unclear, don't do it. All right, particularly don't accept responsibilities that are not within your scope of practice. All right, sometimes people ask you to do things that you really cannot do. It's a huge responsibility, but we want to help you to protect yourself from a lawsuit. Okay. Again, delegating duties, we've talked about a million times, and you probably will talk about that in leadership again. It's so important, and that's one of the major pieces of management of care on your NCLEX. Delegating of responsibilities. Be sure you know what your staff members can do, what they can't do, what they've been educated on, what they understand. Make sure that you are giving correct orders, very clear guidelines as to what you're asking them to do. Make sure you supervise them, excuse me, to making sure that they are doing exactly the way they're supposed to be. So delegating is a huge piece. Now, nurses, excuse me, I'm so sorry. Nurses should carry their own malpractice insurance. It's relatively inexpensive. It's about, I think it's about $80 a year, maybe a little more, but that's real cheap compared to others. Nurse practitioners, they pay a huge amount, and doctors, oof, lots. And I think the last time I checked, OB doctors, they have a huge insurance price, malpractice insurance price. But right now, you are under the ECPI. But as you move out into your practice, be sure you get some malpractice insurance. Okay. Even though your hospitals have some type of insurance on you, nurses should have their own, really, because you never know. You might go outside and you go down to the 7-Eleven and something happens, and you don't have insurance, and your facility is not going to cover you outside of your hospital. That's the thing. Okay. Some other things on malpractice, be very careful with. Remember when we talk about the DNRs or the A&Ds, remember A&Ds allow natural death. DNR is do not resuscitate. Be sure that you are following that. Make sure you know the code status of your patient. That's why you read those charts, to make sure, okay? If you give CPR, or if you fail to give CPR based on their living will or based on their request, then that could be considered a malpractice suit, okay? Another type of thing to think about is if you have a patient who's on Coumadin or some other blood anticoagulant, right? And we fail to monitor the lab results, such as the PT, the INR, the platelet count, those things. If we fail to monitor those and something happens to this patient, and the patient, say, hemorrhages, then you can be held liable for a malpractice suit as well. If you have a patient, let's say you're working in like a rehab hospital, and you are helping a patient into a whirlpool, and the patient is dependent upon you, right? If we do not properly support that patient getting in and out, and while they're in that whirlpool or swimming pool, whatever it might be, and we don't supervise them carefully, that could be a malpractice suit as well. If you accidentally give the wrong food to a patient, you've heard a lot about nutrition in your nursing program. If you give the wrong food, the wrong diet, or a patient aspirates, dies from taking the food, or something else happens, then that patient actually can be considered a malpractice. It's kind of scary. Wait, I'm sorry?
I have one question.
Yeah, sure.
Back to when you said, let's say if a nurse is gonna go ahead and watch someone's cubitin level, let's say, they check their PTINR,
Yeah.
and then it leads, I guess, to malpractice. Wouldn't it first be negligence, and then if they're gonna sue, then it would be a malpractice lawsuit, or because wouldn't it?
Yeah, remember that malpractice is a type of negligence. But if it's proven, remember those three things that's proven, then it becomes a malpractice. So initially it might be negligence on the patient, but if the patient hemorrhages and something, if they hemorrhage, there's going to be some kind of physical problem. That's going to be malpractice. It might have, yeah, because malpractice is a type of negligence. Okay, but this usually with malpractice, there's money involved. And a patient has been harmed, the nurse did not perform their duty. For instance, let's go back and look at that. It's a great question. If you're the nurse and you have a patient who is on, say, warfarin, Coumadin, and they have to go every week and get a PT and INR, and you're the home health nurse, and for several weeks you kind of overlook it, and this patient starts having bleeding problems, all right? First of all, what is the duty of the home health nurse? Well, the duty of the home health nurse was that patient. They were legally bound to take care of that patient. That's why they're there. And so what happens? The nurse failed the standard of care, because we know as nurses that we must check the INR and PT, all right, for anyone who's on this anticoagulant Coumadin. But for 2 weeks, the nurse has not done that. So that's the second one. The third piece that has to be proven is this: did the patient have any effects, any adverse effects, basically? Well, yes, the patient hemorrhaged. And that's where you're looking at a malpractice. But there's 3 things that really have to be present. Make sense?
Yes, thank you.
Sure, yeah. And of course, situations that could result in malpractice. A lot of things can be negligence until something really happens, all right, physically to the patient or mentally. The wrong medications obviously could result in a malpractice. Just giving someone the wrong medication. Let's say we give, somebody wants some Tylenol, all right, and we give it to another patient, but nothing happens to the other patient, but we know he gave the wrong med. We have to write up an incident report, all right, or a variance report. Well, that's a negligence because we failed to perform as a professional, all right. However, if something happens to the patient, it's probably going to wind up being a malpractice suit because of the effects of, say, the Tylenol. Maybe this patient was a liver patient and we gave him Tylenol and something happened, okay. The other one here that's listed is inappropriate defibrillation. So class, if you are going to, you're learning EKGs, right? Yeah? Are you excited? Yes, okay, I am, okay. All right. If you're doing your EKGs and let's say you're in a code and you don't fibrillate a patient correctly and something happens to the patient, well, that's inappropriate. Or if you defibrillate someone and they didn't need it, all right, maybe you did it and they were fine and they didn't need to get shocked. or electrocuted, basically, is what happens. That could be a malpractice suit as well. But all those things have to still be proven. All right. All right. There are a lot of legal things that we look at in nursing. Okay. So is this question true or false? Nurses can be protected from malpractice suits if they are following the accepted standard of care for their profession. What do you think? Can they be protected? Yes, even in a malpractice suit, if all these things do happen, if a nurse is following the standard of care, because remember, it starts with negligence, then the malpractice may not go back and hit the nurse. It might be the doctor, or it might be the hospital having to pay, or there may not be any money at all. But generally, it does have some type of monetary association with it. So the best thing to do is follow those accepted standards of practice, all the things that you have learned, all right? And plus many, many more. You're going to learn so much more when you get out there and become the nurse, all right? So HIPAA, confidentiality, is just simply another one that we talk about all the time. You're familiar with HIPAA. I won't talk too much about it, right? Patients, when they look at their charts, they can actually control what's in their chart and how it's used and how it's disclosed. So for instance, if you have a physician or healthcare provider who you have access to most of your medical records, when you review those records and you see something wrong, please be sure you speak up. I'm sure by now that you have seen some errors in medical records, right? Many patients don't realize that mistakes are made. We're human. People are human, and even the transcribers are human. And so sometimes the patient could not have high blood pressure or hypertension or hyperglycemia, and yet it's listed in their medical records. So that's why patients should have some control over those medical records and how that information is used. And we sign tons of paperwork, of course, for that as well. And we do have, as patients and people, have access to our medical records. But of course, there's policies and procedures that the patient has to go through in order to have access to their records, right? So we need to know about those policies and procedures and how we are protecting our patients. What about patient consents? We've covered this quite a bit. So we do know that our patients must know everything, that there's as much as we can possibly tell them about a procedure. They have a right to make their own choices and their own decisions as long as they understand everything. For medical or surgical procedures, remember, we have to have a consent. They cannot be coerced. Also remember that the nurse only witnesses the signature and witness that the patient was not forced to sign the consent form. Be sure not to do that. All right. You have to think about, of course, the mental status and those types of things as well before a patient is allowed to sign those informed consents. One thing to kind of keep in mind is what we call blanket consents are really not valid and may not be held up in court. For instance, a consent not to follow thickened liquid diet. That's a blanket consent, and that means I'm not going to follow a liquid diet. That's not really valid. All right, so we don't generally do those. If we have a specific thing that we want for our patients, such as they're going down for, let's see, maybe a CT scan with contrast, they have to have, or an MRI, they have to have a consent form. So we just need to remember that, okay? Again, I mentioned earlier that when someone comes into the healthcare, there's a consent. So we sign a lot of stuff, but a bath, a meal, medications, our patients need to consent to that. Some of it's going to be verbal. But there's all kinds of consents that they sign. Many times patients don't know what they're signing. But those are things that are common, you know, giving a bath and serving someone food and giving medications. That's why we do all this education and teaching and document. Don't forget to document all of that to show that your patient did kind of consent to taking the meds. All right. All right. So elements of informed consent include all the following except what? Y'all remember the consent form, right?
The time required to complete the procedure.
Absolutely. The time required to complete the procedure has a lot of other things on there. It describes the procedure, its purpose, the alternative treatments to the procedure. The doctor talks about the expected consequences, any kind of risk, and all of that. And so they are entitled to know all of that information. All right. We've already mentioned the elements of an informed consent. Be sure to remember to make sure the patient is alert and oriented. They can ask questions. Be sure that the healthcare provider is the one that's taking care of that consent form. We cannot influence our patient in either way, all right? Because a lot of times the patient can say, well, what should I do or what would you do? Be sure you don't say, I think you should, all right? Because that's going to be considered coercion. And especially if something happens, well, the nurse said, that could get us in trouble, all right? Be careful with that. What about competency? Competency, usually if a patient comes into the hospital and they are unable to consent, or into the facilities and they cannot give consent because maybe their mental status, usually there is a next of kin who assumes that role, particularly if they don't have a durable power of attorney or an advocate or any of those things. Sometimes court appoints advocates for those types of patients if they don't have any next of kin. But the power of attorneys are completed while the patient is still cognizant. So even now, we should be having a power of attorney completed now before something happens to us. And our older patients need to be aware of that before something does happen to them. Okay. All right, so let's talk about incapacity to make decisions. In the long-term care setting, patients, their mental status, or what we call cognition, fluctuates back and forth. Sometimes they're lucid, other times they're not. It could be their medical condition is causing it, maybe oxygen levels, maybe it's the medications they're taking. So just remember, particularly with our older clients, that you never assume that a patient, if they are admitted and they're alert and oriented ×4, that they're going to be that way tomorrow or the next day or the next week. So you have to constantly assess these patients. All right. So under the definition of a power of attorney, I've given you a little definition here as well. All right. So incapacity, I can't even say the word. Incapacity. Oh, there it is. Incapacity. Sorry. Defined. So basically, unless the patient has been judged incompetent by a judge, people are entitled to make their own decisions. Sometimes, if there's not enough time to get them to the judge, because you know that could take time, the next of kin or some surrogate, someone else, could be appointed by the facility, and that's when you have your lawyers involved and ethics committees and stuff like that. Court-appointed guardians are monitored by the court system to make sure that the finances and the property of the patient is legally managed and correctly managed. And there are some, what we call professional guardians, who have gone through all this training, and they are guardians of multiple people. Of course, they get paid for it too. So that's another job. And there are different what do you call it, titles of those companies for people who are guardians, and they're legal guardians and they work with the court system. We've talked quite a bit about staff supervision and risk. Again, I've already mentioned this. Let me check the time. I didn't realize what time it was. Ooh, it's 12:19. Ooh, okay. But we do know a lot about this. We've talked about it, that you will be held responsible, particularly for the unlicensed person, all right, who works under you, right? So again, try your best not to allow staff to work without help, without the right kind of equipment, because the nurses who do that, if you're in a supervisory role, if you know that there's a problem on your unit, you don't have enough staff, that you don't have enough equipment, that you're out of normal saline, all of those things need to be documented, because the responsibility as a supervisor will go on the shoulders of that particular nurse. All right. The other thing is, as a supervisor, brand new entry nurses, in other words, you will be an entry nurse when you get out there into the field, must be fully oriented. And I would like to suggest that as you go out and find yourself a job, be sure that your facility, wherever you decide to work at, has a nice mentorship program. It's safer that way. You get a lot more one-on-one help. They used to not have a lot of these graduate nurse, what they call preceptors or mentorship programs. That's something new that hasn't been around but a couple of years. And many times brand new graduate nurses would be thrown into some type of charge nurse position, and they fail. They don't do well. Not all, but many of them did not do well because they didn't have enough, orientation. They didn't have enough understanding of what they need to do. So be sure that you're going to a place that wants to take good care of you and make sure you're well oriented to whatever job you have. We know everything we can about the medications, the 6 rights. All right. So always question anything that doesn't look right. All right. As far as what you know about medications. When you talk to your doctor and it doesn't make sense to you, you don't want to point fingers and say this is not right, but inquire if this is what they meant. All right. If this is the amount of medication prescribed for a particular patient. That's why it's important to be able to calculate, because doctors use the weights, whether usually it's in kilograms, as you know, you've done a lot of those, to make sure that the patient's getting a safe amount of medication, but they may have made a mistake when they calculated it, so be sure you are calculating as well. Restraints is another issue. As you know, with restraints, they're very highly regulated, and anything that will restrict movement is considered a restraint. So we always try to do the least restrictive thing to keep the patient safe. Bed monitors, wander bracelets, things that wait, so we can find out where the patient is. So if we are going to have to use restraints, don't forget, you got to know how long, why we're doing it, how often should be released, generally 30 minutes for neurological checks. All right. Just make sure you're checking those neuro and your circulatory systems at least every 30 minutes. Generally, it's about every 2 hours to take the restraints off, do some range of motion. So you need to know how long this restraint needs to be on. The doctors usually write all this, but you be sure you ask them if they have not written everything. All right. The other thing we have to document is what did we try before we put the restraint on this patient. All right. And of course, your skin checks, I've told you, things like that. Remember, one of the things about restraints is that it actually increases patients' injuries. It causes them to be more anxious. If somebody ties you down, it makes you more anxious. So the use of restraints is, we don't like to do that, but sometimes we have to. So keep an eye out on your patients. If they start to decline in their status, their mental status, because they're tied down or have a restraint on, that's important for us to be able to assess and approach that. Okay. So the statement here that's true related to the use of restraints is definitely about the Omnibus Budget Reconciliation Act. It specifically talks about restraints in acute care settings. All right. By the way, geriatric chairs are considered restraints, so we have to be very careful about the use of those. All right. Always try to use alternate restraints before you actually put a real restraint on there. All right. And orders for restraints are required everywhere, not just in hospitals. Telephone orders, remember this is all legal stuff. Be sure you know your telephone orders, okay, what to do. We hope that they are writing them on their computer. Now with the little PDAs they use and the computers, a lot of times they're actually typing in the orders. But it's important to understand what the order is, that it has all the things that you've learned about what needs to be in an order, the route, the dose, the time, those types of things. And even written orders can be misread. So watch the drugs that are similar in names, that sound alike. All right. So be careful when you're reading those orders, particularly even if they are typed in there. Be sure you're writing them down correctly. And when they are actually given you over the phone, be sure you read back everything they say to you. All right. Again, 24 hours is about the max. They have to generally have a physician signature within 24 hours if you're taking it on the phone. And I will tell you, so many times in nursing, something's going on with the patient. We call the doctor on our phone, but they give us an order over the phone. We write it down. And we have to keep in mind that you better see an order from that doctor in that medical chart, that EMR, within 24 hours. Okay, so whatever telephone orders you get, write it down, read it back, keep it on your list to make sure that you go back and find that order. And doctors nowadays are pretty good about doing that, but sometimes they get busy. Okay, so be sure you do that. Don't forget about DNRs. We've talked a little bit about that already. Okay. All right, so there's all kinds of policies for the DNR policy. Every hospital, every facility has some type of policy related to DNRs, right? And there is a lot of DNRs or ANDs, allowed natural death, in our older population. All right, we mentioned all of these things already. And we've kind of said all that. One thing we didn't really mention much here is nurses should not be the legal witness to a will. If your patient wants to write a will, you should not be a witness, sign the witness. Be sure you get someone else to do that. And of course, usually if they want to sign it and they're in the facility where you're working, there's lawyers and other people that can come and take your case managers and people like that who can come do it, but not as a nurse. You do not want to be a legal witness to that will. Okay. All right. Elder abuse, really need to be watching for. This is a major issue. Whoops, sorry. So these are some signs and symptoms. Let me tell you some of the signs and symptoms of potential abuse. You might want to write these down. I think they're also in your book, by the way. Delay in seeking necessary medical care. If we have an older patient who doesn't come into the doctor, they kind of like trying to stay out of the doctor's office. If they are malnourished, if they're dehydrated, if they have strange bruises when they shouldn't have bruises, particularly if they smell, have very poor hygiene, and their grooming is not very good, and yet they're living with someone. All right, that's kind of a marker there. If their clothing is urine smelling and stained, There could be something going on. Again, these are just potential abuse, but you observe these things. If there's any strange markings on the genitalia, it could be a sexual abuse relationship with someone. All right. If they're not receiving their medications appropriately from whoever's doing that with them, be sure to keep that in mind as well. All right. Lots of repeated infections or injuries, the same things. They have an existing disease, but they keep getting complications from that disease. Keep that in the back of your mind when you are assessing your patients. If an elder person doesn't want to talk about what goes at home, they're living at home or in a nursing facility or anywhere for that matter, and they don't want to talk about the problems or home life, they're kind of evasive. That's, you have to do a little bit more discussion with them to make sure they're not having any kind of abuse. All right. If you are nursing, working in home health care, and you're working with a lot of elderly patients, and they have unsafe living environment, needs to be reported. All right. Then you report it back to your company you're working for, and then they take it from there. Okay. If a patient is very suspicious or depressed or anxious, there's a lot of reasons patients are like that, especially our older patients. But we want to kind of keep in the front of our mind when we are taking care of elderly patients that there is a lot of physical, emotional, sexual abandonment. The terms are up here for you. Exploitation of our elderly population. It's terrible. It's terrible. These people are so abused in some cases, right? So just make sure you know what's going on in your state about the laws to report abuse as well. All right, last but not least is how do you safeguard yourself legally from all of this? Always remember, do not work under any circumstances that will create a risk to safe patient care. You don't have to work under those conditions. And if it is, if something's going on in that facility, wherever you're working, you notice that there's some very dangerous things that are going on. It's filthy, it's not clean, whatever it might be, you don't have to work there. So refuse to work under any kind of circumstances that actually could cause a risk to your patient, to safe patient care. And so again, all of these things, will help you safeguard yourself legally. All right.
I have a question on the safe patient care. So
Sure.
if we were to come, clock in, they give you your assignment and the workload's too much, when you ring it over, like as soon as you accept it, and then basically how do you could just clock out, right? Like without accepting it. Like I'd rather just lose my job versus like losing my license because I don't want to take care of, 6 patients as a new grad or something like that.
Okay. Well, first of all, if you're talking about 6 patients, that's really common. 4 to 6 patients is common. Sometimes you might even have more than that. However, if you go to your job and they've given you 10 patients, or it's 6 patients and you're uncomfortable, you need to talk immediately to the charge nurse and explain how you feel. You don't want to take the report for all 6 of those patients and decide to leave or clock out. You've abandoned your patients. That could be considered abandonment in the world of nursing. So once you've accepted responsibility, you got to do what you got to do. So if you do walk into that situation, be sure you're talking with your nurse manager. All right. First your charge nurse, and then of course your nurse manager. Let them know how you feel. And if you have 6 very heavy patients and you know that it could be detrimental or risky for your patients, only the nurse yourself would have to make the decision, am I really going to be working here? You'd have to think about it. So what I would recommend you do as a brand new nurse is to, when you interview for a job or once you get the job. Let me just say this before you start asking too many questions. Got to be careful on those interviews. But you could ask, what is the usual number of patient load for a nurse, the patient-nurse ratio, okay, particularly for new graduates. I've seen new graduates get 5 and 6 patients, and they do fine. But if you're uncomfortable, you have to think about yourself as well, all right? But whatever you do, please don't take exception. You're going to take all those patients, and you're going to get the report, then you've accepted responsibility for the patients. And then they can really frown on that if you abandon your patients. You don't ever want to just walk out, okay? It's a tough one, but I think what you'll do, you'll learn when you get into transition. I've been out in transition with students, and they'd be working with a nurse, and they might have 5 patients. Now, you won't be given medications by yourself. You're not supposed to. Okay, medications always have to be with that registered nurse. But you may have 5 patients, but that preceptor will be working with you, but they will eventually let you take care of more than 1 or 2 patients, because that's what you're out there to do, is to learn how to do that. But they'll be right there with you. So you will learn how to deal with too many patients when you actually walk into the transition program and you work with an RN side by side. You'll have no instructor with you. It'll be just you and the RN. It's actually very exciting. Students love it. Is that exciting?
Yeah, it's exciting and scary.
It is scary.
Terrifying and everything, because you never know. You don't want to risk that license you worked so hard for, but then you want to do, what you want to do.
Absolutely, it is frightening. Here, let me get off of here, and then we'll talk some more about that. I want to hear y'all's thinking. So here, to prevent unsafe care, know the policies. Obviously, that's going to be true, right? Okay. All right, so that's all of legal. The only thing we got left is sexuality, which we can do next week. Okay. All right, so who was the one that asked me the question? I couldn't see. Who asked the question? I think it was a great question.
Hi,
Was
Grace.
that you, Grace?
Yeah.
Okay. Yeah, I am excited. Honestly, I love to see students out in transition. I'm not assigned this time, but I'd love to hear the stories they come back with. But when I was with students in transition, I would go out and meet maybe twice, maybe 3 times. That's it for the whole 144 hours that you have to do. But I remember walking down the hallway and I see that student in those purple pants. You can always tell ECPI students, right? And they have their stuff with them. They're in conversation with doctors. They're in conversation with the nurse they're working with. And it is so wonderful to see how you, as new nurses, soon to be registered nurses, are in there just absorbing all of this excitement. So I'm excited for you. I cannot wait to hear some of the stories that you bring back. All right, so be sure you share that with me, everyone. All right. Again, you will learn how to deal with too many patients. I'll be honest with you, in my early days of nursing, I did a lot of PRN type work. You go out and you work at different places. I worked at a hospital, and it was an orthopedics floor, and that's a tough floor to work on, right? We've got all this equipment and stuff. I got 14 patients. I know that sounds like horrible. I managed, but what was really funny in the morning, they weren't real friendly there. I didn't work there but once, I think. But in the morning, I was so exhausted. I was still there like it was a night shift. I was still there like at 9:30 in the morning trying to do all my stuff. And the other nurses had already gone home. But yeah, that was a bad sign. But some states have patient-nurse ratios that you can only take so many. Generally, what we see, it happens differently from facility to facility, but what's really nice is usually like a PCU might have 4 or 5 patients. PCU is a progressive care unit. They're like a step down, sort of a step down from your ICU. maybe 4 or 5 patients. ICU usually has 2 to 3 patients, maybe. Med surges might have maybe 5 or 6 patients. So be sure you ask, what is the patient ratio for the position that I'm applying for, or what is the general ratio? And I think that's important. Nurses have tried for years to get states to say, let's pass a law that says we've got to have a nurse-patient ratio, because it was killing nurses, that many patient care. But I think California started the wave. I forget, anybody going to California to work? Anybody? I'm just curious. No one? Because I'm just kind of curious. Because I know California kind of started it years ago. I don't think Florida has I don't think it has a nurse-patient ratio yet. But it would, what do you think, Melissa? Yeah, I know you're working out there.
I was going to say, no, I'm not working out there, but I follow a lot of nurses on Instagram, and California is the only state that has a law about ratios.
I knew California, they always start everything. We know that it kind of comes across the country, but many states have been trying to get that for a long time, and so far it hasn't happened. But check with your facility.
Doesn't
I know
California have a nursing union?
Yes, I think they are in a union. They sure are.
Which is what sets those ratios, right?
I think so. Yeah. Some hospitals are unionized in the state of Florida. I just don't know which ones, but I've heard that there are some. So you want to find out all this information before you do your homework on your job, your prospective job. Do your homework on what kind of governance is there. What?
HCA has unions.
HCA is a unionized. Okay. All right. And if, I think doing homework about before you go for a job, it really helps, but you really won't know until you actually start working somewhere. Nothing's ever perfect, right? Never. Okay. All right. Does anybody have any questions about the legal or ethical issues or anything else? Anybody okay? All right. Hopefully that was just a review for you. But what's really exciting is next week we're going to start talking more about the older adult, the common aging changes. I love to talk about those. Those are really, some of them, but it really comes to forefront when you really start talking about aging. Rest and sleep and spirituality. So those are the 3 things in Tuesday's class that we're going to cover. Okay. To get started. And then it just gets more interesting. This is just the introductory kind of stuff. All right. Okay, I have 12:40. I'm going to allow you to leave today because I want you to prepare for that 2 o'clock exam for those of you who are choosing to take it. I will still be right here in class. I'm going to let you kind of study. Let me just call it study, okay? I usually don't let students out this early. However, I did not want to start another conversation because I do have some videos I want to show you when it talks about sexuality. We talk about how does a nurse really assess a patient who's a gerontological patient or a geriatric patient about sex. And we're going to use what we call the implicit model. And there's a video that we're going to watch. Okay. And then I also have another video. It's called The Passage of Time. And it's a documentary. It's only an hour long, but it's a documentary in which they interview older people and ask their opinions about their life and do they feel old. And of course they have young people in there as well, and even babies. They're cute as buttons. So it kind of talks about the passage of time and how many elderly people are feeling about being old. And I think that would be a really good video to kind of wrap up this first couple of weeks here. So we have those things to do, and I didn't want to start those now, okay? All right, so any questions about anything, and then I'm going to let you go, and I'm going to get your exam all set to go. Right. Be sure, though, when you are, if you choose to take this exam, be sure that you're showing me your little simple calculator, please. Okay, because that's what I discussed with Dr. Trainer, and she agreed that I could do this. Okay. All right. And again, you don't have to take the exam. If I don't see your name in the list on the second exam, and again, it's going to be the first exam. All right. The other one's going to be trashed. I would say trashed. Then I will use the first exam grade. All right. It's totally up to you. Okay.
Thank you for that.
All right,
Oh.
thank you, Professor.
Well, thank you. And yeah, because see, I want y'all to pass as quickly as possible, because Monday, some of y'all are going to go to clinical, right? Is it Monday? And maybe some of y'all could give meds, but you
Just
have
Saturday,
to.
we're going to clinical.
Saturday.
Oh, some of you are going Saturday?
We already went Monday.
Oh, you already went. Oh, we got to get this thing done so y'all can give some meds. Yeah. All right. No problem. All right. Well, I will see you back here. I will be on Teams, just like I did this morning.
They're
I'll
not
have
letting us give meds. They're
Oh,
not
you
letting
can't.
us give meds.
Oh, you're not giving meds at where you're at. Where are you working at, Steve?
JKZ.
Is that John
John
Knox?
Knoxville. Yeah.
Oh, okay. Well, I'm sure
Okay.
there's reasons. There's reasons, and I don't know all the reasons, but we want you to get through this dosage calculation. Remember, it's you got to make a 90 or above. If you get 90, you don't have to worry about it. It's over and done with. It doesn't affect your grade, but and you have to pass it. You have 3 chances to pass it. The one this afternoon will still be number 1. Okay.
Okay, Professor Stevenson, sorry for cutting you short. I just want to know or be sure of the name of students who's gonna take it the second time.
Okay, I'm sorry. Can you show me your face? I can't hear you hardly.
Oh, this is Tommy.
Oh, Tommy, yes. What is it, Tommy? Let me get a little closer.
Yeah, you said it's not for everybody. But I want to ask this question, how do we know who and who to take it? That's what I'm saying.
This I cannot give grades out. That was also an agreement between Dr. Trainer and I. I can't tell you your grade. However, if you want to go through it again, you can.
Okay.
So you have to decide as a student whether you want to go through it again. It's exactly the same test, class. Same test.
Okay.
I'm not changing it. Okay.
Just another heads
right,
up on that calculator. If people use the calculator and got answers, I remember from last time that it happened, they're sometimes off by 10 times. So even though you think that you may have gotten an answer, it could be off 10 times, because that's what happened when I was taking them with Dr. Wheeling.
Oh, okay. So yeah.
If you think you had the right answer, I would question it sometimes, even though the calculator gave an answer. That's why I'm retaking it. I'm going to retake it because I'm scared of what that calculator does, because it does some weird stuff.
Yeah, but with a regular calculator now, it will be better for you. All right. And from now on, we will allow, most likely we'll allow calculators if you have to take it the second time as well. Okay. Remember, when you are for your exam, like your exam next Thursday, you're going to have dosage calculations on that, and I'm pretty sure we're going to be giving you our calculators here at school, because we have those calculators. So there's no issue for you. Okay. All right. Well, it's been fun. I feel like I did all the talking. I was going to get you to do some more talking. All right. So I will see whoever shows up at 2 o'clock. I will be on class here as well as in Teams, and I'll be available. All right. So enjoy some lunch. Okay. All right.
Thank you.
All right.
Thank you.
Thank you. I need to take a roll here real quick. Hang on a second. All I need to do is hit my button here. Yeah. Okay. All right. Be good. I'll see you later. I have an attendance in here I can check. Take care.